All right, so we're going to talk about body dysmorphic disorder. It's really easy to dismiss body dysmorphic disorder as just not liking a body part, but that's not what this is. That, in fact, this is about people who really dislike a body part because they see it as being disfigured in some way. So it's not just, I wish I had a different nose, but that my nose is disfigured. And in fact, other people are noticing that and thinking that, and perhaps it's all they think about when they see me. So it really goes beyond just like, I wish I had a different body part. The other thing to think about is how disruptive body dysmorphic disorder is. That this is not, again, just I don't like my nose, but I think my nose is disfigured. And people can spend 3 to 8 hours a day on average thinking about that body part and thinking about their body in this way. And that is a lot of our waking hours. And so this is really a significant disruption. Every hour you're thinking about, every minute you're thinking about a body part that feels disfigured to you is a minute you're not thinking about or doing something else. And so this really is disruptive to functioning in some very real ways. Another way of thinking about how significant this disorder is to think about the fact that like almost a third of people with body dysmorphic disorder have actual delusions. And delusions are beliefs that have no factual basis. So this is where the idea that somebody's nose looks perfectly fine and they're convinced that it's disfigured, right? That would be kind of delusional, as opposed to somebody who maybe does have a crooked nose and now they just can't stop thinking about it, right? Which would also be body dysmorphic disorder if it was disruptive in that way. But the delusional piece is when there's they're seeing something that other people simply can't see. Up to a fifth of people with body dysmorphic disorder wind up having plastic surgery to correct the thing that they think is problematic. So all of this speaks to the significance of this disorder. More women and men have this, which probably culturally is not surprising, and it begins in late adolescence for most people, or at least in adolescence sometime for most people, which makes sense in terms of when we start reflecting on our sense of identity and when we tend to start paying more attention to our physical appearance. So this idea that we're focusing on pieces of our body, right? My nose, my wrist, is consistent with what we know, that people with body dysmorphic disorder do have a tendency to look at parts rather than the whole when they're making decisions about things. So beyond their body, if they were looking at a picture, let's say a picture of a forest, they would be more likely to pay attention to the individual trees than to look at the whole forest and have an experience of the whole forest. So that cognitive trend, right, is seen everywhere, but winds up leading to certain ways of looking at one's body. The other thing is that people with body dysmorphic disorder tend to overestimate how important attractiveness is to self-worth, not just for them, but also for other people. So that they tend to think that this is more important. What their nose looks like, for example, is more important than what the average person thinks about the importance of what their nose looks like to who they are as a human being. One of the things that can be difficult for people, for students certainly, but for people in general, is to make the distinction between body dysmorphic disorder and eating disorders. And there's a couple of things to think about with that. First, as we're talking about it, right, body dysmorphic disorder is more likely to be, and almost always, about specific body parts as opposed to weight, which is a global thing. Whereas eating disorders are typically about weight and the distortions in body image that happen with some eating disorders. And we'll talk about this in a couple of chapters, but the distortions have more to do with the size of your body overall than about specific parts. The other thing, though, is that where you have experiences and behaviors that might meet both body dysmorphic disorder and eating disorders, if they meet the criteria for eating disorders, we're going to go with an eating disorder diagnosis. And part of the reasoning for that is that there are specific treatments we would engage in for an eating disorder that would be important to access. And also that eating disorders tend to be more directly threatening, or can be more directly threatening to an individual's well-being. And so that is going to be the default if they meet criteria for both. Another way of thinking about the significance of body dysmorphic disorder is information about recovery. So if you read this sentence, over an 8-year period, 75% will recover. At first glance, that might seem, that's not bad, right? But the reality is that 8 years is a long time to get to a 75% recovery rate. And even after 8 years, 25%, a quarter of people with a diagnosis will not have recovery. That's less good. And so this is something that in some ways is relatively treatment resistant. And so that people who are struggling with it will struggle for long periods of time. And so that adds to the significance of this. Not surprisingly, perhaps, we're going to see a lot of overlap with disorders we've talked about recently. So major depressive disorder, social anxiety, obsessive compulsive disorder, all have co-occurrence with BDD. But in addition, we see high rates of substance use disorders and personality disorders with people who have this disorder as well. It's likely that having a personality disorder, especially a personality disorder like, for example, borderline personality disorder that we'll talk about near the end of the semester, puts you at more risk for body dysmorphic disorder. Borderline personality disorder involves disruptions to sense of self, sense of identity, and so that would make sense with body dysmorphic disorder. It's also likely that having body dysmorphic disorder might put you at greater risk for substance use disorder if you're using substances to manage the discomfort that comes with the symptoms of BDD. And the treatment we're going to offer almost always is going to be cognitive behavioral therapy. We might also use SSRIs to address the same brain chemistry and brain function issues that we talked about with OCD. But we also will use cognitive behavior therapy to address some of the problematic ways of thinking that contribute and sustain the symptoms of BDD. Okay. Hoarding disorder is another one of this group of three, right? OCD, body dysmorphic disorder, and hoarding disorder are all interrelated. Hoarding disorder used to be a subheading of OCD or a specific kind of OCD, but we've separated it out into its own disorder now. But all of them have connections in terms of having obsessive thoughts, and in some cases, especially with OCD and hoarding disorder, compulsive behaviors. We do see compulsive behaviors sometimes with BDD, but they also all have overlap. If you go back and look at those slides about the brain in the OCD lecture, you can go back and reflect on that and see how hoarding disorder also probably has similar brain disruptions. And you can think about what it says on those slides in terms of what the disruptions are in ways that might lead to hoarding disorder symptoms and behaviors. And so essentially, right, hoarding disorder is that the person has intense anxiety if they try to get rid of hoarded objects. And that the obsession is the need for the object, the compulsion is the actual hoarding of the object. And 2/3 of people with hoarding disorder don't even realize the ways in which their hoarding is problematic. They've normalized it in some way. And about 1/3 of people who have hoarding disorder will also hoard animals. And I'm sure you've seen these stories on the news where somebody is, we see that 50 dogs have been rescued from a hoarding situation. And in that case, it's just, right, that just happens to be the focus of the obsessive thinking and compulsive behavior for that person with hoarding disorder. People with hoarding disorder have more general difficulties with attention. They have difficulty categorizing. So if you think about hoarding as a difficulty categorizing what I need and what I don't need, they have that, but they also have broader difficulty categorizing things if we give them cognitive tasks, asking them to categorize, and in general have difficulty making hard decisions or making black and white decisions, stay or go, get rid of this thing or don't get rid of this thing, even aside from the hoarding context. And so, right, the biological basis I said already, are similar here. We are going to, again, apply Mauer's two-factor theory here so that the focus here is on the negative reinforcement that the person gets for their avoidance behavior, right? Hoarding is an avoidance behavior in the sense that they're not throwing things away. Throwing specific things away creates anxiety. If I keep them, I can avoid that anxiety. And so we do use exposure and response prevention in the same ways we talked about it with OCD. And so, right, so we do that. We also do here add some cognitive behavioral therapy, and almost always will include SSRIs in the treatment as well. All right, so the next video is going to be on post-traumatic stress disorder, and that'll round out the chapter for us.